What if I tell you that just by asking the right questions, you can not only diagnose erectile dysfunction, but also pick up hidden problems like heart disease or diabetes? In part 1, we understood what erectile dysfunction is, along with its anatomy, causes, and pathophysiology. Now in part 2, we move to the most important part: how to approach a real patient. We will go step by step, starting with history taking, then physical and neurological examination, followed by important lab investigations, and finally the management options. And if you haven't watched part 1 yet, make sure to check it out first. This video is directly linked to it and will make much more sense once your basics are clear. Now, first, how to approach to a patient with ED. When a patient presents with ED, the goal is not just to treat erection, but to identify the underlying cause. Because ED is often the marker of systemic disease. When a patient presents with ED, the goal is to figure out whether the cause is physical, that is organic, psychological, or mixture of both. First, you should assess the onset. Did it happen overnight? As sudden onset is a classic sign of psychological trigger. Or did it happen gradually over years? That's usually point out the physical cause, often vascular issue. Importantly, ask about nocturnal or early morning erections. If a patient wakes up with firm erection but cannot achieve one during sex, in this case, the machinery is working fine. The issue is lightly psychological. If they have lost morning erections entirely, it points towards a physical cause like blood flow or nerve damage. While taking history, it is important to assess lifestyle and risk factors because ED is often closely linked to vascular health. In fact, ED can act as an early warning sign of cardiovascular disease, since the penile arteries are smaller and tend to get affected earlier than coronary arteries. So we should always ask about habits like smoking, alcohol use, and obesity, as well as chronic conditions such as diabetes and hypertension. Another important part of history is reviewing the patient's medication, because many patients are not aware that their drugs can contribute to ED. So we should carefully look for commonly implicated medications such as antihypertensives, especially thiazide diuretics and beta blockers, antidepressants like SSRIs, and hormonal drugs used for conditions like hair loss or prostate disorders. Keeping in mind that medications are a reversible cause of ED. After history, the next step is physical examination, which helps us to localize where the problem might be. We begin with a vascular assessment by checking blood pressure and peripheral pulses, especially in the lower limbs to evaluate the overall blood flow. Then we perform a genital examination, where we assess the size and consistency of the testes. Since small, soft testes may suggest low testosterone, and also look for any plaques or scar tissue in the penis, as seen in Peyronie's disease, which can lead to painful or curved erection. A brief neurological examination is also important. Simple reflexes such as cremasteric reflex, in which we stroke the inner thigh to see if the testicle moves or not, help us to assess whether the nerve pathways between the spinal cord and genital region are intact. Finally, we look at secondary sexual characteristics such as body hair distribution and the presence of gynecomastia, as these can provide important clues toward underlying hormonal imbalances. After history and examination, we move to targeted laboratory testing. While the aim is not to order unnecessary tests, but to identify common and treatable causes. We start with hormonal evaluation, especially total testosterone levels, which are ideally measured in the morning when they are highest. If testosterone is low, further testing such as prolactin may be required. because high prolactin level suppresses the release of GnRH. Since GnRH is responsible for stimulating the anterior pituitary to secrete LH and FSH, a reduction in GnRH naturally leads to decreased levels of these gonadotropins. Among them, LH is particularly important because it stimulates the Leydig cells in the testes to produce testosterone. So when LH levels fall, Leydig cell stimulation decreases, and ultimately this results in reduced testosterone production. That's why we check prolactin levels if testosterone is low. Next, we assess blood sugar levels, typically with HbA1c to detect undiagnosed diabetes. Finally, a lipid profile is important, as high cholesterol can lead to vascular disease and reduced blood flow to the penis, contributing to ED. In most patients, history, examination, and basic laboratory testing are sufficient to guide diagnosis. However, in selected patients where the diagnosis is unclear, specialized testing may be considered. This includes vascular studies such as penile Doppler ultrasonography or cavernosography to assess arterial inflow and venous leakage. Now, the treatment of erectile dysfunction. We must first recognize that management begins with patient education and lifestyle modification, addressing underlying risk factors such as obesity, smoking, and alcohol abuse. Furthermore, as psychological factors like performance anxiety or relationship stress often play a role, involving a partner in the educational process is highly encouraged, primarily due to the fact that a supportive environment markedly increases the success rate of any clinical therapy. The main oral drugs used for the treatment of erectile dysfunction are sildenafil, tadalafil, vardenafil, and avanafil. All of these belong to a class called phosphodiesterase 5 inhibitors, which act by blocking the enzyme phosphodiesterase 5 in the penis. Normally, phosphodiesterase 5 breaks down cGMP, but when we inhibit it, GMP levels increase, leading to prolonged smooth muscle relaxation and improved blood flow, thereby enhancing erection. However, it is important to remember that these drugs do not initiate erection on their own. They require sexual stimulation to work. These drugs are effective in a wide range of conditions, including psychogenic, diabetic, vasculogenic ED, post-prostate surgery, and spinal cord injury, which is why they are considered first-line therapy. They are usually taken in graduated doses, and their onset of action is roughly 30 to 120 minutes, depending on the drug and factors like food intake. Among them, tadalafil has a longer duration of action, while avanafil has a faster onset. Now, certain precautions are important. Lower starting doses should be used in elderly patients, those with renal impairment, or those taking drugs that inhibit the CYP3A4 enzyme like erythromycin, ketoconazole, or grapefruit juice, because these can increase drug levels and risk of side effects. In terms of safety, these drugs act as mild vasodilators, so they can cause hypotension, especially when combined with alpha blockers, although they can be used together cautiously if the patient is stable. The most important contraindication is with nitrates, because this combination can lead to severe, life-threatening hypotension. Common side effects include headache, facial flushing, dyspepsia, nasal congestion. Some specific effects. Sildenafil may cause temporary blue-tinted vision. Tadalafil may cause back or muscle pain. Rare but serious concern. Possible association with non-arteritic anterior ischemic optic neuropathy, so avoid in patients with prior history. Another important point is that these drugs do not affect libido, ejaculation, or orgasm. They only improve erection. In patients with low testosterone, combining testosterone therapy with phosphodiesterase 5 inhibitors may improve response. Before labeling a patient as non-responsive to PDE5 inhibitors, we must first check whether the drug was used correctly. First, the patient should have had an adequate trial. That means the medication should be taken on at least 6 different occasions at the maximum tolerated dose. Many patients try it once or twice and conclude it doesn't work. That's not sufficient. Second, you need to check food interaction, especially with sildenafil. If the patient takes it after a high-fat meal, absorption is delayed and the drug may not work properly. So timing with meals is important. Third, and very commonly missed, is lack of sexual stimulation. These drugs do not cause automatic erection. They only enhance the nitric oxide pathway. So if there is no physical or psychological stimulation, for example foreplay, endogenous nitric oxide will not be released and the drug will appear ineffective. Fourth, timing of the drug is crucial. Each drug has a different onset. If taken too early or too late, the effect may not be optimal. Finally, always consider unrecognized hypogonadism. If testosterone levels are low, the patient may not respond well to phosphodiesterase 5 inhibitors alone. In such cases, testosterone replacement along with the drug may improve outcomes. Phosphodiesterase 5 inhibitors can be used for long term, as long as they are effective and well tolerated. These drugs are not addictive, and they do not lose their effect over time in most patients. Many patients use them on demand for years, especially in chronic conditions like diabetes or vascular disease. Next is androgen therapy or testosterone replacement is used in patients with erectile dysfunction only when there is confirmed testosterone deficiency. In such patients, testosterone plays a supportive role, and combining testosterone therapy with phosphodiesterase 5 inhibitors can improve response in those who do not respond to phosphodiesterase 5 inhibitors alone. However, an important principle is that testosterone should not be given if levels are normal, because it does not improve erectile function in such cases and only adds unnecessary risks. There are multiple ways to give testosterone, including transdermal patches and gels, injectable forms like enanthate or cypionate, and subcutaneous pellets. Oral forms are generally avoided due to the risk of liver toxicity, except for newer preparations like testosterone undecanoate. Now, regarding safety, testosterone therapy does have some concerns. There is a possible increased risk of thromboembolic events along with side effects like fluid retention, especially in heart failure, worsening sleep apnea, and other metabolic effects. However, when used appropriately and monitored carefully, it may actually improve metabolic health, including better insulin sensitivity, improved body composition, and reduced risk of metabolic syndrome and cardiovascular disease. A very important clinical point is that in men with secondary hypogonadism who want fertility, testosterone should not be given directly because it suppresses spermatogenesis. Instead, drugs like clomiphene citrate are preferred as they stimulate the body's own testosterone production. Finally, patients on testosterone therapy must be regularly monitored, typically at 3 to 6 months and then annually. Monitoring includes testosterone levels, symptom improvement, and side effects such as gynecomastia, prostate issues, erythrocytosis, liver function abnormalities, and reduced fertility. Investigations like hemoglobin and PSA should be checked periodically, and therapy should be stopped if there is no clinical benefit within about 6 months. When oral medications like phosphodiesterase 5 inhibitors are not suitable or ineffective, we move to second-line treatment options such as vacuum devices and local therapies. First, vacuum constriction devices are a non-invasive option. These devices work by creating a vacuum around the penis, which draws blood into the corpora cavernosa, and then a constriction ring is applied at the base to prevent venous outflow and maintain the erection. They are especially useful in patients who cannot take oral drugs. However, they do have some limitations. Patients may experience pain, numbness, bruising, and altered ejaculation. Next, if oral therapy fails, another option is intraurethral alprostadil, prostaglandin E1. This is administered as a small pellet inserted into the urethra using an applicator. It works by causing vasodilation and increasing blood flow, leading to erection. Around 65% of patients respond in clinical settings, although the success rate at home is somewhat lower. One advantage is that it has a lower risk of priapism compared to intracavernosal injections. Intracavernosal self-injection involves injecting drugs like alprostadil directly into the corpora cavernosa, which produces erection by direct vasodilation. This method is quite effective, with success rates around 70 to 80%, but many patients discontinue it because it is invasive and uncomfortable. The dose is carefully titrated, and in some cases, combination therapy with drugs like phentolamine or papaverine is used to enhance effect. However, it is contraindicated in patients at risk of priapism, such as those with sickle cell disease or hypercoagulable states. Common side effects include pain, prolonged erection, and fibrosis with long-term use. Now, if all medical therapies fail or are not suitable, we consider surgical options, mainly penile prosthesis implantation. These can be semi-rigid or inflatable devices. Surgery is usually reserved for patients who either do not respond to medications, cannot tolerate them, or prefer a more permanent solution. Although it is an invasive and irreversible option, it has low complication rates and very high patient and partner satisfaction, making it a reliable last-line treatment.